My name is Ryan Todd. I'm a paramedic at Johnson County EMS. Today we're going to talk about opioid overdoses and some considerations on how I think they should be ran. Objectives for today are going to be we're going to define different prescribed and illicit opioid medications that are common in our field, review some signs and symptoms of opioid overdose. We're going to talk about treatment of overdoses and some different ways of doing things that aren't talked about as often as I think they should be. And then we're going to discuss some post-overdose resources that are available specifically to Johnston County. So before we get into all that, we're going to talk a little bit about the why I chose this. It kind of comes down to the fact I've been involved in EMS close to 10 years. I responded to many overdoses, both as an EMT and a paramedic. So I've been filling in kind of the support job of the EMT, if you will, as well as the lead job of the paramedic. Some of these overdoses were not managed well, which caused a lot of negative patient-provider interactions, be it the patient getting violent with us or providers having really bad attitudes with patients. We've all seen it and we've all heard it. The provider just treating the patient like dirt and yelling at them and all sorts of other things. These negative interactions that get so common the longer you're in this field. They decrease the likelihood of patients or bystanders calling for help when they need it, which would lead to increased accidental deaths from overdoses. Treating these patients poorly will not get them to make a change. If you go to an overdose patient and just absolutely treat them like dirt, it's not going to convince them that they should change their actions and become get clean if that's what they want to do. Having compassion and empathy for these people may be more likely to help them in the long term, help them to seek out further care, get into rehab, and try and make a change in their life. A little further on in the presentation, we're going to go more in depth and talking about anoxic brain injuries and how what we do and the way we do it can sometimes cause that, which can worsen the negative patient provider outcomes. Here we have a graphic of the Big Four, which I borrowed from this company, Fully Involved. It's a fire department training company, but I think it applies to EMS as well, not just overdoses, but overall. It's called the Big Four, which is kind of just the rules of the job that they've described. So for do your job, we can translate that to EMS as practicing and using the best evidence-based techniques available to you. Treat people right, practice empathy and compassion with patients, not just experiencing opioid overdoses, but especially with those patient populations as well. Give an all-out effort, no matter if it's a patient's first or 500th overdose, we still want to treat them as best we can. Treat them as a human being. Don't be super upset and salty with them when you have to go to them. Provide the same high level of care that you're trained and able to do. Have an all-in attitude, kind of builds off of the all-out effort. Commit to providing a high standard of care to each and every patient we encounter. Opioid medications. They're very commonly encountered by EMS. Typically, they are encountered with street drugs like fentanyl and heroin, but they're also prescribed pretty popularly for moderate to severe pain. They can be classified as a synthetic medication, essentially being made in a lab, or they can be derived from the poppy plant, which is what they originally started out as. The exact chemical structure and makeup is a little beyond the scope of this presentation, but that information is out there and available if you'd like. It's one of the most common overdose calls EMS will run. That goes to the fact that there were approximately 81,000 deaths in 2023 that were attributed to opioid overdoses. We can use that number to kind of describe just how many there were just straight overdoses in the US. That number is going to be exponentially higher. These medications are pretty frequently misused. We've all heard it. It's become a very common thing to hear about. Some common ones that you'll see can be Percocet, morphine, Dilaudid, hydro or oxycodone, fentanyl. There are many, many others. They're coming out with new ones every day. The single bolus that we currently give for morphine and fentanyl is not shown in the long term to cause addiction. What they have found causes the addiction is the prolonged use of opiate medications, such as if you break a bone, your doctor prescribes you codeine or fentanyl or one of those medications, and you take it consistently for months on end, and you build that tolerance, and all of a sudden the doctor stops prescribing it to you, and now you are turning to quote street pharmacists for your medication. So the 81,000 deaths in 2023 was actually lower than in 2022. The data is showing that accidental opioid overdose deaths are going down. In 2023, DEA seized over 80 million pounds of fentanyl-laced fake pills and almost 12,000 pounds of fentanyl powder. Some effects that you'll see on patients who are under the influence of opioid medications. Um, it's going to be drowsiness, confusion, nausea, and a sense of euphoria. What the medicine is actually taken to do is to block the pain receptors and cause the release of dopamine in the body, which results in feelings of euphoria, which is also why people end up abusing this medication. That same loop with the release of dopamine reinforces the repeat use of the medication, makes you want to take it more, makes you want to take it more often. It can also cause changes in mental status, drowsiness, and hypoxia due to the patient not breathing an adequate amount per minute. We'll commonly see pinpoint non-reactive pupils even when they're awake. It's not just if they're unconscious. Their skin may be pale and show signs of cyanosis, which goes back to the hypoxia. And from what we know, the prolonged hypoxia can result in an anoxic brain injury, and it's unknown if that damage to the brain can be reversed. So, opioid abuse, it should be treated as both a medical and a mental health problem. There's typically something that causes these patients to want to abuse opioids. One, it's the chemical dependence that their body has developed over time, as well as whatever demons they're running from that may be affecting their mental health. The receptors in the brain cause dependency on the medication, going back to that mental health side of the house. It's a small group of prescription drug users that may progress to using heroin. It's typically due to cost and availability of the medication. So, like the example I talked about earlier, where you were prescribed something and then all of a sudden now it's no longer available to you, you got to get your fix somehow. As the time frame of use lengthens, the longer you take this medication, your tolerance will increase and your dependence will worsen, much like many other addictive substances. In 2011, the White House released a intra-agency strategy for responding to the prescription drug crisis, which was focused primarily on education on opioid risks, tracking prescription drugs, medication disposal, and then enforcement. Around that time period is when we saw a big push kind of on social media and through public health departments, pharmacies, prescribing Narcan, not because the doctor prescribed it, but because they're issuing out an opioid medication. They just went ahead and included a little Narcan spray, such as the one pictured on the screen. The plan was ideally to focus on prevention for current users, trying to push out education to allow them to know the risks and kind of what to look out for if they started to find a dependence was building, as well as establishing new methods of treatment for current users. Here in Johnston County, we have established a post-overdose response team, or a PORT team, that will respond with us to overdose calls and try and connect patients that are seeking help with resources for treatment. We'll talk about them a little more in a couple of slides. This team is run through the community paramedic program. One of the resources that they've made available to us is these little Narcan kits that we leave behind after responding to overdoses. It comes with the intranasal spray, It's a single use, kind of like an EpiPen almost, and it comes with a little bit of literature for what to look out for bystanders and everything like that. So going back to the EMS side of the house, first responder treatment, the patient that we get called out to is usually found unconscious, unresponsive with sonorous respirations, usually at a very slow rate. It's not uncommon to see respiratory rates around 2 to 4 breaths a minute. Very ineffective. They're not getting adequate tidal volume, adequate oxygenation for their body. They'll have non-reactive pinpoint pupils. Shining even a brighter light in them will not get them to constrict or dilate anymore. For whatever reason, they may be covered in cold water, milk, ice cubes, any sort of liquid. I don't really know why people do this, but it's a thing that happens often enough that I felt I should mention it. While we're establishing control of the patient's airway and kind of taking over their breathing for them using a BVM or some other route of oxygenation, we should be gathering a good history as we can to help rule out any other differentials, as well as completing a full vital sign assessment, heart rate, blood pressure, SpO2, end tidal CO2. I like to grab a blood glucose as well as a temperature, just so we can rule out any other factors, because patients will typically not just have one single medical problem. They may have one or two. It may be an overdose with low blood sugar or super low body temperature due to the aforementioned water or ice cubes that have been placed on them. We should also consider the presence of a polypharmacy overdose. Opioid medications are commonly mixed with amphetamines or cocaines. Those are called speedballs, or your local lingo may be different for your area. Excuse me, I'm going to take a drink. Like I said before, EMS treatment should revolve around fixing the oxygenation problem before we administer Narcan. And the reasoning for that goes back to the anoxic brain injury I talked about a few slides ago. If we go out to these patients who have been hypoxic for an unknown amount of time before we get there and we just immediately slam as much Narcan as possible, we've all seen the memes, law enforcement, 20 milligrams Narcan to a diabetic, stuff like that. Those memes are sort of based in reality. It's kind of the downside of the proliferation of the EpiPen style Narcan administration is they don't get to control how much they give. It's just straight 4 milligrams every time. So what will happen is these patients will commonly get 10, 12 milligrams of Narcan before we get there. You'll get there with your BVM, give them some oxygenation and ventilation. These patients will wake up. When they wake up, I've seen them projectile vomit profuse amounts. They wake up, they're very confused. They're sometimes violent, agitated. You hear a lot of stories about EMS and first responders getting assaulted because of this. Well, the reason they wake up that way is because their brain is hypoxic. They don't have enough oxygen going to their brain to allow them to mentate normally. So they wake up in that fight or flight sympathetic response, and most of the time they choose fight. Uh, we can also kind of understand where they're coming from. Say, you're unconscious in your house. Last thing you remember is you were doing some sort of opioid medication, and all of a sudden you woke up. There's, your ambulance crew, potentially your first responders, supervisors, law enforcement officers. You got all these strangers inside your house that were not there when you passed out. So if you think about it that way, it's kind of understandable as to why they wake up and don't really want anything to do with us, and they don't really want to see us. While we're fixing this oxygenation, we should be utilizing positioning using a head tilt chin lift technique or a jaw thrust, whichever one works for you and is appropriate for the situation. That a lot of times will open the airway and help you to alleviate those sonorous respirations to make sure that they don't have an obstruction. Using this method may also require you to place an NPA or an OPA. I've had good success using an NPA to help relieve the airway obstruction and allow us to deliver good ventilations and good oxygenation to the lungs. I enjoy using the BVM for these cases. It's a lot easier for us to kind of help their intrinsic respiratory rate as well as provide a little bit quicker than that 2 to 4 breaths per minute. Anywhere from 10 to 12 breaths per minute is going to help you fix the oxygenation issue. So we've talked a lot about fixing the oxygenation issue, and going back to that point, the way we can tell they're having an oxygenation issue is back to the skin signs. They're going to be cyanotic, pale, clammy, whether that's due to the water or they're sweating. But we can also use SpO2 to determine their approximate level of oxygenation. And I say approximate because we all know that the SpO2 pleth and number is got a couple of minutes of lag behind what's actually circulating in the bloodstream. So it's not uncommon to go to these patients and see astronomically low SpO2 readings. I've seen down to 4% on room air. Typically, they're in the 50s to 60s. So that should clue you in pretty quickly that they're not breathing appropriately, they're not exchanging enough gas. So we can use our BVM and our ventilation techniques and airway techniques to try and bump that number up. I typically shoot for about 90 to 94% before I start to think about Narcan. What I found is that kind of keeps me from having to redose these patients over and over and over again. And when they wake up, they're still a little confused, but they're not outright agitated or violent. It, by doing this, it allows the body to kind of circulate that oxygen through the brain, regain some perfusion, and take them somewhat out of that fight or flight state. Our goal is to establish an adequate intrinsic respiratory rate. We don't necessarily want these patients to regain consciousness. If they do, it's not a downside, it's not a terrible thing, but if they don't, it is what it is. So Narcan is typically administered intranasally with an atomizer, like the one pictured on the last slide. I don't really prefer this route for a couple of reasons. One of them being it's extremely difficult to gather a a accurate dose when you're pushing it intranasally, and it is especially difficult to do that when you're having to put the amount of force through the atomizer to properly atomize the medication so it'll be ingested through the mucous membranes. What I like to do, I like having IV access for these patients because it allows me to be a lot more conscious of how much Narcan I'm actually giving and allows me to give it at a lower amount and a slower rate. For Johnston County, our dose is 0.4 to 2 milligrams of Narcan for adults, pretty much across the board for intranasal, IV, IM, whatever route you want to give it, and 0.1 milligrams per kilogram for pediatrics, again, pretty much across the board. So we'll talk a little bit more about Narcan, kind of go a little bit more into detail about the medication itself. So Narcan is the antidote for opioid overdose. Um, Recent studies and thinking have showed Narcan was beneficial when given in cardiac arrest, but reading through the study, you can find that it was primarily given to younger patients with initial shockable rhythms, which is favorable for gaining ROSC on those patients. In my opinion, more research is needed to determine if Narcan was truly the benefit that it was in those cases, or if they were patients we were going to get ROSC on either way. So Narcan, like we said, it's widely available from many pharmacies and health departments. I know here in Johnston County, If you go to the health department, you can request Narcan kits and they will give them out for free, which I think is great, and it's a good resource if it's utilized. Many law enforcement agencies will also issue Narcan kits to their officers. I know that's fairly common around here as well. They'll get to the scene of an overdose first and use their kits, which can sometimes be an issue, but it's in the best interest of the patient using the tools that they have, so I can't fault them too much for it. A lot of overdose patients may have received at-home Narcan from a bystander or, like I said, those law enforcement officers that got there before we did. And going back to my point about, giving the 20 milligrams of Narcan to the diabetic, that shows the importance of gathering a full assessment before we go go and give medications to patients, because your medical director is not going to be happy with you when he reads through that chart where you gave a diabetic patient a crap ton of Narcan before you thought about giving him D10 or D50 or anything like that. While it's a very rare side effect, extremely high doses of Narcan have caused pulmonary edema in patients, typically in hospital. That's not typically something we see pre-hospitally, but it's something to think about. If this patient's received, I would say about 8 to 10 milligrams of Narcan, you should focus more on the ventilations and oxygenation, and a lot of times that will kind of get the medication to work a little bit better, restore their respiratory rate, and potentially restore consciousness to them. Like I said, I prefer the IV route. It's easier to control the dose. You know exactly how much you're giving versus the intranasal. It uses the exact same setup as if you were giving it intranasally. Instead of adding a mucosal atomization or the MAD device to the front of it, you just connect it to your Luer lock port on either your IV tubing or your Luer lock on the J loop or whatever those are called in your area. So going back to some specifics about Johnston County, I mentioned we have the post overdose response team or PORT team. They went into service on July 1st of 2024. Their primary role is for overdose response, like it says in their name, but they also do provide community paramedicine services and crisis intervention response for mental health. Uh, what they can do is they will meet with the patient either at the scene or at the hospital if we end up transporting them, and provide the patient with different options for recovery and support. Work on linking those patients to different detox centers based off of what they overdosed on, or local area or patient populations, anything like that. And if the patient does decide to enter into a medication assisted treatment plan, they can actually administer Suboxone in the field. They will do that once daily for a week while they get them referred to a long term treatment center. Uh, I have never seen that anywhere else before. I think that's a pretty neat little program they got going on over there. Their goal is to help reduce the number of repeat overdoses that people have and get the patient to longer term help instead of just, EMS coming out, narcanning them, telling them don't do that again. And then, you're going back to them 2 weeks later for the same thing. These repeat overdoses can cause the anoxic brain injuries we talked about, which can lead to permanent brain damage, which, to put it lightly, is not good for the patient. So, some key takeaways that I'd like for us to have from this day is that opioid related use disorders have risen for many years, but within the last 2 to 3, we've finally seen a decrease in the amount of overdoses. I wasn't able to find out what they attributed that decrease to. It could be any number of things, from not being reported to people are switching medications. The education programs may be working. Treatment of these patients revolves around fixing the oxygenation and ventilation prior to administering Narcan. Like I said, our goal is to provide the best quality care that we can. So if we're waking these patients up and they're getting violent and then we're having to go down a whole nother treatment path to sedate them before we transport them, it can potentially cause further injury to the patient. It can potentially cause injury to responders. It's going to result in a negative interaction. And as we all know, everyone everywhere is recording at all times now. Anytime they see an ambulance, a police car, fire truck, the phone comes out and the camera comes on. I don't know about y'all, but I do not like being on camera. I don't like recording myself, so I try to spend the least amount of time being recorded and being shown on the news as I can. It may be different for your local areas, but look into some different resources that your area has for helping these patients. Like I talked about here, we have the post overdose response team, Narcan kits available at pharmacies, health departments, hospitals, anything like that. And overall, remember that we should treat these patients with the same respect and dignity that we would treat anyone else. Just because they're suffering from opioid disorders doesn't mean that we get to treat them poorly. A quote that I can't remember who said it or where I heard it, but it goes, "It's not what you do that matters, it's how you make them feel that they'll remember." And to break that down, it kind of means it doesn't matter if you missed every IV attempt or dropped something on their foot or anything like that. But if you make them feel like dirt, they're going to call and complain and not have a good interaction. But if you treat them like people, treat them with respect, be nice to them, they will remember that and be more likely to enter into a recovery plan because they feel like they matter, and then they can hopefully get better.